Hello students, let's study about coagulation. So coagulation is a mechanism of the hemostatic mechanism, that is to stop the bleeding. Hem means blood and static means to stop. So the clot, which is composed of network of fibrin threads and cells like RBC, WBC and platelets and plasma, adhere to the vascular opening. Therefore it adheres to the opening and then it prevents blood loss. So now what are the steps? So there are mainly three steps. So after the damage of the vascular tissue, thromboplastin is released. So thromboplastin converts prothrombin into thrombin, then thrombin converts fibrinogen into fibrin, and then fibrin monomer forms fibrin polymer when they all come together, and then with the cells it forms clots. So all these coagulation factors are in inactive state when it is in the fluids blood, but when the damage to the vessel takes place, the clotting factors, that coagulation factors get activated, and then they convert one inactive factor into the active factor. Now we'll see coagulation factors. So there are total 13 in number. So they are by Roman numbers. So first fibrinogen, second prothrombin, third tissue thromboplastin, fourth calcium, fifth labile factor, sixth name is not given, seventh stable factor, 8 anti-hemophilic factor, 9 Christmas factor, 10 Stewart power factor, 11 plasma thromboplastin antecedent PTA, 12 Hegman factor, and 13 fibrin stabilizing factor, that is FSF. So these are total 13 factors in the coagulation process involved for the clotting of the blood and to stop the bleeding when the blood is oozing from the blood vessel, so that there should not be more blood loss. Now we will see what are the bleeding disorders or hemorrhagic disorders. So they are total divided into three types: vascular defect, platelet defect and coagulation factor defect. So because of the vessel defect or platelet defect or coagulation factor defect, there is bleeding continuously and then it causes bleeding disorder. Now we will see few examples of these defects. So vascular defect, it can be acquired. So it can be in infection like bacterial infection, typhoid, tuberculosis, or viral infection like chicken pox, rubella, measles, the pox, or because of the drugs or because of the vitamin C deficiency like scurvy. Then congenital, it can be hereditary hemorrhagic disease. In platelet defect, it can be qualitative or quantitative. So qualitative can be congenital, like platelet disorders seen in congenital disorder like Gleisman's disease, Bernard-Soulier disease, or Gray platelet syndrome. Then quantitative, so when the total normal platelet count, that is 1.5 to 4.5 lakhs per cubic millimeter. So if it is less than 1.5 lakh per cubic millimeter, it is called as thrombocytopenia. So causes of thrombocytopenia can be acquired or congenital. So in acquired, it can be because of the drugs like heavy antibiotics or chemotherapy drugs, or chemicals, leukemia like aplastic anemia, AIDS, liver disease, massive blood transfusion, or infection like dengue, P. falciparum infection. Then in congenital, it can be TORCH group, that is toxoplasma, rubella, cytomegalovirus and herpes or syphilis, and then congenital leukemia. Then increased platelet count is called as thrombocytosis, and it can be seen in infection or it can be seen in chronic myeloid leukemia. Then causes for the coagulation factor defect. So they can be congenital or acquired. So congenital, when the hemophilia A, that is factor 8 deficiency, and hemophilia B when the factor 9 deficiency, or it also called as Christmas disease. Acquired causes can be liver disease, anticoagulant drugs like warfarin, heparin, or massive blood transfusion. Because of that, the blood gets diluted and the platelets or coagulation factors, they become less, and then it causes hemorrhagic disorder or bleeding disorder. Now we will see investigations of the bleeding disorders. So routine investigations can be CBC, and after that you can do bleeding time by capillary method, also called as Duke's method, clotting time by capillary method or venous method, platelet count, and in peripheral blood smear you can see morphology of the platelets and other cells, and tourniquet test. Then special investigations can be prothrombin time, partial thromboplastin time, activated partial thromboplastin time, thrombin time, coagulation factor assay like factor 8, 9 or others, then platelet function test. So you can see morphology of platelets in peripheral blood smear. Then megakaryocytes can be seen in bone marrow aspiration or biopsy, and then platelet aggregation test, platelet adhesion test. So these are all special investigation for the investigation of bleeding disorders. And there can be investigation of fibrinolysis. So these are clot retraction and clot lysis test, fibrinogen assay, and FDP, that is fibrin degradation products. Now the next is the fibrinolysis. It is breaking down of the fibrin clot. So the clot is dissolved in the blood vessel, and then blood flow again starts in the blood vessel. So the mechanism, the fibrin clot, there is plasminogen activator within the clot, so which activates plasminogen into plasmin, and then plasmin converts fibrin into the fibrinogen degradation products. The investigations of the fibrinolysis are clot retraction and clot lysis time, fibrinogen assay, and fibrinogen degradation product assay. So let's see coagulation disorder. So one of that is hemophilia. So it is an inherited genetic disorder in which mechanism to stop bleeding is impaired, so which results in bleeding for longer time after the injury. So there are two types: hemophilia A because of the clotting factor 8 deficiency, hemophilia B because of the clotting factor 9 deficiency. So it is X-linked recessive disorder inherited from one X chromosome of one parent. So females are mostly carriers. So clinically there is mild type when the factor 8 is more than 5%, so it bleeds only after major trauma. Moderate type factor 8 is 1 to 5%, it bleeds only after minor trauma. And moderate factor 8, if it is less than 1%, then it bleeds spontaneously and also associated with the deep bleeding. So clinically, bleeding after injury, dental procedure, surgery, accident, then internal bleeding, joint damage, bleeding into soft tissue, muscle, skin, gums, mouth, stool, urine. So complications are deep bleed in muscles causes swelling, pain, numbness in limb. Joint bleed causes hemorrhosis. Then intracranial bleed causes loss of consciousness, brain damage, death. Investigations: coagulation profile, clotting factor is prolonged, prothrombin time is normal, APTT is increased, clotting factor 8 or 9 low. Treatment: hemophilia A, clotting factor 8 is given, hemophilia B, clotting factor 9 is given. Von Willebrand's disease, it is most common hereditary disorder due to qualitative or quantitative defect in von Willebrand's factor VWF. It is a larger fraction of factor 8, so it is factor 8 VWF complex which circulate in blood. The function of it is coagulation and platelet adhesion. It is synthesized in endothelial cells, megakaryocytes and platelets. So clinically in that disease, the spontaneous bleeding from mucous membranes and from wounds. Types: type 1 most common, mild moderate decrease in von Willebrand factor 50%. Type 2 it is less common, so VWF is near normal. Type 3 it is rare, so VWF is not detectable and low factor 8. In treatment, cryoprecipitate or factor 8 concentrate should be given. Investigation: platelet count normal, platelet aggregation with ristocetin is defective, bleeding time prolonged, plasma VWF factor is reduced and factor 8 is also reduced. Let's see DIC, disseminated intravascular coagulation. So it is thrombohemorrhagic disorder in some systemic diseases. So etiology can be massive tissue injury because of trauma, surgery, infections like gram-negative bacilli, meningococcal infection, widespread endothelial damage that happens in burn. Miscellaneous causes can be snake bite, shock. So here the activation of coagulation is there, then thrombotic phase will be there, then consumption phase, then secondary fibrinolysis, that is FDP, fibrinogen degradation products are formed, then bleeding, then ischemic tissue injury, microangiopathic hemolytic anemia. So clinically patient will be having bleeding and some organ damage, that is kidney or brain. So investigation profile, platelet count is low, PBS shows RBC cystocytes, fragmented RBCs. Then coagulation profile like PT, APTT, TT are prolonged and FDP is raised, that is fibrinogen degradation products raised. These are my references from where I have taken my notes, and I hope you find this session very useful for your academics and for your future practice. Thank you so much.